So we have Dr. Bhalla, and he'll be talking about the recent advances in pharmacotherapy for glaucoma management.
Thank you, Dr. Harsh. Uh, the topic that I'm going to cover is the advances in medical management of glaucoma. We all know that glaucoma is a chronic progressive optic neuropathy leading to damage of optic nerve, and the single most important modifiable risk factor is raised intraocular pressure. Glaucoma is a growing concern. It's second leading cause of irreversible blindness globally, and we had 80 million people affected by this disease by 2020, which was increase of about 20 million since 2010, and this number is bound to increase by another 32 million by 2040. So, and what is the Indian scenario? 12 million people affected, 1.2 million people are blind from the disease, and unfortunately more than 90% of these cases remain undiagnosed. As far as medical management is concerned, we have come a long way. 1876 we had the first drug of cholinergic agonist, pilocarpine. Then in 1904 we had osmotic agents. 1954 saw the advent of oral carbonic anhydrase inhibitors. 1978, almost 100 years after pilocarpine, we had beta blockers like timolol. And then 1987, alpha agonists like brimonidine. 1995, topical carbonic anhydrase inhibitors. 96 saw advent of prostaglandin analogs, and in 2017 we had Rho kinase inhibitor introduction. So where is the need for newer drugs? We want to improve health related quality of life, drugs which also offer additional neuroprotection with minimal side effects, longer half-life, which are more potent in IOP lowering with lesser side effects. And there is also need for preservative-free drugs, drugs which are economical and which improve the patient adherence with alternative drug delivery systems. So some of these drugs are available in India, like ROCK inhibitors, but the drugs still not available is nitrogen oxide donor, latanoprostene bunod, 0.024%. If we classify newer pharmaceutical agents, we have ROCK inhibitors, we have A1 receptor agonists, small interfering RNA, cannabinoids, latinculin derivatives, big potassium, calcium ionic channel modulators, and newer prostaglandin analogs, along with antioxidative agents, neuroprotective agents, and also neurotrophic agents. If we talk of latinculin B, the literature says that how it acts is actin depolymerizing agent, and so it decreases the outflow resistance through the trabecular meshwork, causing mean IOP reduction of close to 32 to 34%. Nitrogen monoxide donors like bunod, how it acts is, it relaxes the trabecular meshwork cells and inner wall of Schlem's canal. It plays a role in assembly and disassembly of endothelial adherence junctions, besides increasing the uveoscleral outflow, and it also regulates the ocular blood flow. So this is the drug latanoprostene bunod, 0.024%, and it also causes a significant rise of intraocular pressure by about 30%. Effect starts about 1 to 3 hours after the first dosage, and the maximum effect comes about 12 hours after this instillation. There are studies like Lunar and Apollo which have demonstrated that the non-inferiority of latanoprostene bunod compared to timolol maleate, and another study, Voyager, have concluded that this drug has better IOP reduction than prostaglandin analog latanoprost. Then we all know what are prostaglandin analogs. The first one introduced which received FDA approval was bimatoprost, and then came travoprost, and the latest drug prostaglandin analog to get FDA approval is tafluprost. So these drugs act on 9 types of receptors have been identified for prostaglandins in the human body, and the PGFP and PGE are the 2 main types of receptors. But now there are future developments in prostaglandin analogs which act on other receptors also, like PGE2 and PGI2. Latanoprostene bunod is one which acts on PGF2, sulprostone acts on PGE2, butaprost on PGE2, iloprost PGI2, and there are also drugs in phase 2 and phase 1 trial which have been named DE117 and ONO9054. Then we have introduction of sustained release implant like bimatoprost sustained release implant by the name of Durista, and it has received FDA approval. It can deliver drug over 4 to 6 months, causing 30 to 35% intraocular pressure drop. Travoprost intracameral implants by the name of ENV515 also cause significant reduction in IOP reduction of about 30%. BKC-free drugs is the need of hour because over 70% of existing multi-dose formulation contains benzalkonium chloride, which promote activation and secretion of inflammatory mediators and also cause delayed hypersensitivity and allergic reactions. And 40% of the glaucoma cases are associated with ocular surface disease, hence BAK-free products are now considered as preferred choice. These are some of the allergic reaction due to the preservative benzalkonium chloride. So there is introduction of self-dispersion nanotechnology, where the right-hand slide shows the drug in the center, which is covered by oil, and which is on the outermost layer is non-ionic stabilizer. Then there is a publication regarding availability of technology to detect apoptosing retinal cells. And it's a novel technique which holds potential as a surrogate marker for glaucoma. ANX776 can visualize and quantify individual retinal cells undergoing apoptosis as a marker of the disease activity. And once you have detected these cells which may undergo apoptosis, then we can target this apoptosis by BCL2, which is apoptosis inhibitor. That seems to be a very revolutionary technology. Then there is talk about gene therapy. Trabecular meshwork is a favorite tissue for gene transfer, and LAC-Z reporter gene carried by adenoviral vector is important one. So also caveolin 1, caveolin 2, and also angiopoietin like 7, which is altered in the glaucoma patients. IOP lowering, currently available IOP lowering medications have some drawbacks, like none of these drugs they target the underlying pathology, that is increased outflow resistance. Then some of these drugs like beta blockers and alpha agonists do not lower intraocular pressure during the nocturnal period. There is intolerance because of side effects, and the target pressure may not be reached even when we combine all these class of drugs. So the need of the hours is agents with a novel mechanism of action, which is directed at lowering the outflow resistance, which is effective both during diurnal and nocturnal periods, and preferably with additional pharmacological properties that also support ocular perfusion and retinal function, and which have minimal adverse effects. So this saw the introduction of Rho kinase inhibitors. The research into these drugs began in late 1990s. 2014 we had ripasudil gained approval in Japan. 2017 netasudil got US FDA approval, and 2020 netasudil was approved by DCGI. So we all know this trabecular meshwork conventional outflow pathway, where the aqueous, which is secreted by the non-pigmented ciliary epithelium, you will see that it goes out through the uveal, then corneoscleral and the juxtacanalicular trabecular meshwork into the outflow channels, into the Schlemm's canal, and through it into the aqueous veins. What happens is that ROX signaling has been identified as important regulator of trabecular meshwork outflow, because trabecular meshwork exhibits smooth muscle-like properties, and these ROC inhibitors act at subcellular level, causing actin-myosin disassembly of these trabecular meshwork cells. So it sensitizes smooth muscle in a calcium-independent manner. I will not go into these technical details. If you just see the slides, you will remember there is actin-myosin. The purple one are the myosin complexes, and the green one is the actin complexes, which get outlined at the border of the trabecular meshwork cells. So what Rho kinase pathways, if you give ROC inhibitors, you will find that the myosin gets localized to the apex of the cells, causing apical flattening, and then there is apical constriction. This is how the outflow channel resistance is decreased in the conventional outflow. So if the ROC pathway is signaling causes enhanced intraocular pressure, there is scar formation after filtering surgery, and there is also retinal ganglion cell and optic nerve damage. But if you give ROC inhibitors, all these effects are counteracted and neutralized to great extent. So this is how the cytoskeletal changes in the trabecular meshwork are brought about by the cascading effect of the activation of the ROC pathway. But drugs like ROC inhibitors, by acting at the subcellular level, causes decrease in the outflow resistance and increase in the outflow through the conventional pathway. So this netasudil, besides in contrast to ripasudil, has some additional mode of action also. It causes norepinephrine neurotransmitter causing vasoconstriction. Then this norepinephrine transporter is also inhibited. It also decreases the episcleral venous outflow, and so it has additional mode of action which it in combination causes decrease in the intraocular pressure. There are drugs like cannabinoids, topical cannabinoids, and not the systemic ones, have been tried, which causes decrease in intraocular pressure by 30%. The drug which has been tried is the tetrahydrocannabinol. Then melatonin analog by the name of agomelatin also has been found to lower intraocular pressure by 30%. There are connective tissue growth factors, and the intracameral delivery of anti-connective tissue growth factor is also being seen as a potential strategy for glaucoma therapy. Trabodenosone, which is an adenosine analog, also causes IOP lowering effect. Then there are non-IOP dependent treatment strategies which goes by the name of neuroprotection, and these are in the form of the antioxidants, anti-inflammatory, glial cell modulation, and the stem cell therapy. So how they act is, there is accumulation of excessive glutamate, and overstimulation of N-methyl-D aspartate receptors causes intracellular calcium influx, which causes activation of the complex cascade, and this causes programmed cell death or apoptosis of retinal ganglion cells. And the drugs which are tried are the neurotrophic factor, brain-derived neurotrophic factor, the ciliary neurotrophic factors, recombinant human nerve growth factors. Then calcium channel blockers also have been tried, and how they act is by we know that this NMDA, N-methyl-D aspartate, is mediated by calcium influx into the neural cells, which is followed by the apoptosis and cell death. So it became logical that if we try calcium channel blocker, it may be rational alternative for neuroprotection in glaucoma. And the drug which has been tried is topical flunarizine 2%, which has been found to reduce intraocular pressure. So the future looks very exciting. Currently, lowering of intraocular pressure remains the only treatment strategy. Sustained drug delivery systems aim to overcome adherence problems, but there are still some unresolved issues like safety, duration of IOP lowering effect, and quality of life. And for future, personalized medicine that considers individual variability in genes, environmental and lifestyle factors for each person hold a promise to predict optimal treatment and prevention strategy for the individual glaucoma patients. Newer medications may be able to extend the duration of medically controlled glaucoma by the prostaglandin implants. Preservative-free drugs may help in preserving ocular surface, and alternative methods of delivery for glaucoma medications may be a key factor in improving outcomes with the currently available medications. With that, I come to the end of my presentation. I also take this opportunity to invite all of you to annual DOS conference, which is going to be held at New Delhi from 7th to 9th October. I'll request all of you to block your dates and please come and attend our conference. Thank you, everyone.